about the anti-hyperglycemic drugs and their impact on the retinopathy. I'll present some of the new data. So, diabetic retinopathy is a very commonly encountered complication that we see in our day-to-day practice, and it is caused by the toxic impact of chronic hyperglycemia causing chronic inflammation, neurodegeneration and microangiopathy. Apart from that, the other risk factors which can accelerate the development of diabetic retinopathy includes the uncontrolled blood pressure, it includes the duration of diabetes and the high HbA1c. Based on the presence or absence of the neovascularization, it can be classified as a background retinopathy, moderate to severe NPDR or PDR. This is what we have been using in our clinical practice, but if we are planning for a clinical research, we need to do our ETDR grading system that includes the early treatment diabetic retinopathy grading. It includes 13 steps, and any progression of more than equal to 3 steps is accepted as a significant progression. We all are aware of the beneficial impact of a tight glycemic control on chronic microvascular complications from the landmark trial, the DCC trial and the UPPDS trial, which have shown a robust reduction in the incidences of diabetic retinopathy as well as the worsening of the diabetic retinopathy in both the cohorts, the primary prevention as well as the secondary prevention. In fact, the DCC trial was the first trial to identify the phenomena of early worsening of diabetic retinopathy in type 1 diabetic patients who were on intensive therapy with insulin. Later on, it was identified in type 2 diabetic patients also, and using various oral anti-hyperglycemic agents, and also been identified in pregnant women who were subjected to intensive glycemic control, and recently in post-bariatric surgeries also. These are the proposed mechanism for the early worsening of the diabetic retinopathy. I am not going to go in detail before this. We'll move forward. Let's look at the impact of individual anti-diabetic agents and their impact on the retinopathy. We'll start with the insulin. As we know, the intensive therapy with the insulin can cause early worsening of the diabetic retinopathy. However, the long-term control is always beneficial in reducing the progression of diabetic retinopathy. Moving forward, regarding DPP-4 inhibitors, there are some experimental research. We have shown that it may have a beneficial effect as a protection of the retina, and some small case studies have shown that the use of DPP-4 inhibitors may be beneficial in reducing the rate of diabetic retinopathy. Regarding alpha-glucosidase inhibitors, there are paucity of new data in this regard. However, the older experimental research have shown some beneficial effect of this molecule. Now, regarding thiazolidinol, they need a word of caution because they have been equivocally linked with the increased incidence and worsening of the diabetic macular edema. However, this causal association between the use of TZD and the DME has not been demonstrated in many of the prospective trials. But still, this need a word of caution if you are planning to use this molecule in your at-risk, high-risk group of patients. Regarding sulfonylurea, again, there is a paucity of new articles in this regard, but whatever older articles are present, they demonstrate a smaller impact on the progression of diabetic retinopathy with gliclazide and glimepiride. Regarding metformin, maybe because of their anti-inflammatory and anti-angiogenic impact, they may act as a protective agent for the diabetic retinopathy, but yet to be investigated. Regarding SGLT2, there are some experimental data showing a benefit in reducing the diabetic retinopathy. Few small-scale studies showing a marked regression in the diabetic macular edema with the SGLT2. This is the meta-analysis of 48 trials involving 40,000 of the patients, in which the use of SGLT2 was compared with the non-SGLT2, and the study showed there was no significant improvement or worsening in the progression of diabetic retinopathy. But when they did the subgroup analysis based on the duration of diabetes, they found that the use of SGLT2 was helpful in reducing the incidence of diabetic retinopathy in patients who have a duration of diabetes less than 10 years. So this could be one more reason to start SGLT2, this molecule in our patients, so that we can offer one more advantage with this. The GLP-1 receptor agonist, a bit controversial agent with regard to the diabetic retinopathy, because there are some controversial results from the recent trials which have shown that the use of this these GLP-1 receptor analog increases the risk of diabetes progression. So whether it is a myth or the reality, let's look at some facts and evidence to demystify that. So this is the analysis of 93 randomized controlled trial involving around 1,06,000 patients, which shows, which basically in this three, all the trials were categorized into three groups: the GLP-1 receptor versus placebo, GLP-1 versus insulin, and GLP-1 versus covalent. And they look for the adverse effect in terms of retinopathy. And the analysis shows the use of GLP-1 increases the risk of progression of diabetic retinopathy in when compared to placebo, but when compared to insulin, the GLP were protected. Then they did a subgroup analysis for the individual GLP-1 receptor, and they found that this albiglutide was responsible for this trend. So they removed the trials with the albiglutide and reanalyzed the data, and the data shows there was no significant association with the use of GLP-1 and the progression of diabetic retinopathy. Another meta-analysis of 6 cardiovascular outcome trials involving 50,000 patients. This is showing the key trial features. We just focus on the two parameters, the HbA1c, which was mean HbA1c was from 7.3 to 8.7. The duration of diabetes was ranging from 10 years to 15 years, and more importantly, the documentation of baseline retinopathy was not recorded in many of the trials. On top of that, only Pioneer 6 trial, they exclude the patient of retinopathy. Rest of the trial, they did not include the retinopathy as an exclusion criteria. Apart from that, if you look at the method of ascertainment, none of the trial used the ETDR grading system to look for the diabetic DR progression. Only the Sustain 6 and the Pioneer 6, they used the fundus photography to look for the diabetic retinopathy. Otherwise, the rest of the trials, they just put yes or no for the presence or absence of the retinopathy. In fact, the retinopathy endpoints definition was also variable across the trial. The results of the meta-analysis showed that the overall use of the GLP-1 receptor was not associated with the worsening of the diabetic retinopathy with the odds of 1.1 and a non-significant p-value. However, the statistical analysis showed a high degree of heterogeneity in between the studies. Then they did the meta-regression in which they looked for the association of fall in the HbA1c and the increasing odds of the retinopathy. And the analysis showed that there was a significant association. There was odds of retinopathy increased by 0.7 for every 1% greater reduction in the HbA1c. The trials which have this smaller reduction in the HbA1c, they faces a lower odds for retinopathy, whereas the outlier trial here, Sustain 6, they had a greater reduction in the HbA1c, so faces a greater risk of odds of retinopathy. So if we look at the Sustain 6 data, the population, there was 3% incidences of worsening of diabetic retinopathy or diabetic-related complication in semaglutide patient group as compared to the placebo. If we compare this whole Sustain 6 population and the Sustain 6 program, there were 79 events. If we look at the baseline characteristics of these 79 patients, it was found that in 79 patients, the duration of diabetes was longer as compared to the rest of the population. They had a higher HbA1c. They had a simultaneous treatment with insulin, 6% of the population, which may have a synergistic impact on worsening of the diabetic retinopathy. If you look at the medical history of the diabetic retinopathy, 83% of the patients, they had a baseline medical history of diabetic retinopathy. Some had proliferative retinopathy and some had the some kind of treatment for proliferative retinopathy. So from this analysis, we can understand the population of Sustain 6 was a high-risk population as compared to the other set of population. Then another meta-analysis It's a very interesting study. It has two parts. In first part, these researchers took the data from the Swedish registry and they took around 2,390 patients, type 2 diabetic with GLP, and they cross-matched with the type 2 diabetic with non-GLP. They observed for the incidence of the retinopathy, and the incidence was much lower in patients who were taking GLP as compared to the non-GLP. The interesting point is here, they did the Mendelian randomization. The Mendelian randomization is a very sensitive statistical analysis or tool to look for the causal association. So what they did, they took the data from the genomic wide association study and they estimate the effect of GLP-1 receptor gene expression and the diabetic retinopathy outcome. And the results showed there was an inverse association between the GLP-1 receptor gene expression in pancreas with the background and severe NPDR, meaning that those patients who had a higher gene expression in the pancreas for the GLP-1 gene, they had a lesser chance of background retinopathy and the severe NPDR. So this suggests that if we give the GLP receptor analog, which proxy and increase expression of GLP-1 receptor gene, might causally reduce the risk of diabetic retinopathy. But still, this need to be defined in further dedicated trials. A small word about the the presence of expression of this GLP-1 receptor in the human eye. The research has shown that the expression is low in the normal human eye, and that too they were detected only in the single cells confined to the ganglionic cell layer of the retina. And when they investigate for their presence in the patients who have advanced proliferative diabetic retinopathy, they did not found any GLP receptor expression, either the protein nor the mRNA. So this suggests that the GLP receptors are unlikely to play a direct role in the worsening of the diabetic retinopathy. Another evidence from the real world data, which includes the data from the US, from the UK and from the FDA adverse reporting system, and all echo the same result that there was no significant association between the use of GLP-1 and the progression of diabetic retinopathy. This focus is a dedicated trial which is being continuing, and they assess the long-term effect of semaglutide as compared to placebo on the development of and the progression of the diabetic retinopathy, which involves around 1,500 patients. They have used the ETDR grading system for the documentation of retinopathy progression. This trial was started in 2019, so maybe by next year, because the duration of the trial is 5 years, so maybe by next year we will be in a better position to understand the exact story. So the take-home message is that most of the reviewed literature on the anti-hyperglycemic drugs have shown that except for the thiazolidine, rest of the anti-hyperglycemic agents